Yes,
Okay.
yes, we should.
Good evening, everyone. So welcome to the third edition series four, third series edition four, I'm so sorry, of the IPS West Zone Branch PG Psychiatry Education Committee's Tenacious Tuesday teachings. And today, the topic for discussion is approach to psychosexual history therapy. It's a mere coincidence that it is on Valentine's Eve, but of course, when we were discussing about topics, we thought that this is one topic which most residents struggle, even after, not just during residency, but even after residency. Some struggle in taking sexual history. So hence, we decided on this topic. I'll just share my screen for the intros. Is my screen visible?
Yes.
Yes, it
So
is.
our chairperson for today is Dr. Suparna Telam ma'am. She has obtained her doctorate in human sexuality way back in 1990, where probably we weren't even born. And she practices as a consultant in sexual medicine at Ruby Hall Clinic, Jangir Hospital, and Usha Nursing Home in Pune. And ma'am, if you could welcome ma'am, if you could introduce our speaker for today.
Oh, yes, of course. Am I audible?
Yes, ma'am.
Well, Adarsh, of course, I know him, but I have to let others also know him. He is a professor of psychiatry at King George's Medical University, Lucknow, has at least more than 140 publications and 20 book chapters to his credit. Also has research projects funded by NIMH, USA's John Hopkins Medicine, and ICMR, etc. He is presently an honorary general secretary of IPS UP State Branch. He is an editor of Indian Journal of Behavioral Sciences, IJBS, Central Zone, deputy editor to Indian Journal of Psychiatry. He is a co-chair to Early Psychiatrist section of the World Association of Social Psychiatry. His areas of interest are vast: cognition and cognitive neurosciences, CBT, human sexuality, and spirituality. Tell me what he is not interested in. I'm eagerly waiting for you, Adarsh, to listen to you. Thank you. Over to Adarsh.
Before Sir takes over, Dr. Shilpa Adarkar ma'am is also here. She is the chairperson of the PG Psychiatry Postgraduate Education Committee. Welcome, ma'am.
Yeah, hello and welcome Dr. Suparna ma'am and Dr. Tripathi. Uh, we have chosen this topic as Prajakta has already said because a lot of residents especially either fumble when they take this history or they don't know what are the details to be asked. It is not just, asking for their sexual relations. It's much more than that. And therefore, we thought that we should have this topic. Unanimously in the committee, it was decided. And unanimously, it was agreed that Dr. Adarsh Tripathi is the best person to speak on this. So I think we are eagerly waiting to hear you. And I also thought that Prajakta has already introduced Dr. Suparna Telang, but she has also been, I think, on the IPS committee of sexual medicine, and who better to chair this session. So I think we have a great combination here, Dr. Tripathi and Dr. Telang. So we are eagerly waiting to hear from you. Please go ahead, Dr. Tripathi.
Thank you very much, chairpersons, Suparna ma'am, Shilpa ma'am. Thank you very much, Dr. Prajakta and IPS West Journal branch team for having me here on this day, Valentine's Day. So happy Valentine's Day, everyone. And I hope that many students are actually celebrating the day rather than sitting in the class. So let it be like that. So I'll be sharing my screen. Just a
Till
minute.
sir does that, just a few instructions. If you have any questions, put it up in the chat box and we will address them later as sir wants to do it. And we also have a quiz at the end of it, just like a small revision for you guys.
So is my slide visible now?
Yes, sir.
Yeah.
Sir, full screen kar dijiye bas.
Is it okay now?
Yes.
Okay.
Yeah,
So as
it's okay.
the presentation is for PG students, so here are I would like to have at least some interaction during presentation also. But to maintain the flow and not to disturb, not to prolong the time too much, I would request that whenever I ask some question, quickly type in the chat box, and so that we can see some relevant questions and adjust my discussion accordingly during presentation. Is it okay? Any resident can type. Is it okay? So I can see that you are not just open the laptop and watching movie.
Residents, you can keep interacting with sir on chat.
I
That would
request
be
some residents to at least put something in the chat. Yes.
Okay.
Yes. Okay.
Thank you. Thank you very much. So what we are going to do in probably next 35 minutes that we'll be discussing how to do an assessment of a case with psychosexual dysfunction. If the person has presented to you with a psychosexual dysfunction, or in another scenario, you are trying to assess sexual history of somebody who is in your usual care. So we'll be talking in context of both these scenarios in this presentation. So before embarking on the real issues related to clinical history and assessment, we'll be talking some of the important and relevant contexts in relation to sexual history. Because sexual history, there are some important things which we need to understand before doing its clinical assessment. Sexuality as a subject, as we all know, that it is influenced by a large number of variables, that it is not only affected by purely biological issues or purely so-called psychological and social issues, but there are a lot of other factors related to cultural factors, upbringing, the developmental influences, media, and there are lot many factors which influences sexuality. And we also need to understand that sexuality and its expressions are intensely varied and consistently changing also. What does this mean? That if a textbook has been written 20 years ago, some of those things and concepts might have altered in the current world scenario because of the significant influences the society is having due to various factors. And several of those influences, so-called modernization and development, is influencing sexuality in a very significant way. So these alterations in normal human sexuality also has a bearing when we are talking to the clients in for the assessment of their sexual problems. So when we are thinking about assessing dysfunctions, disorders, or planning treatment, we need to keep in mind those variations. So here is a very quick question for residents. Can anybody tell me the answer of this question? So how common are the sexual problems? Can anybody guess and quickly type? Just to see. Very good, very good. So good number of people are saying that answer is C. That means sexual problems are fairly common, and roughly 30 to 50% of the people in their lifetime are affected by sexual problems. So as a general basic concept, we need to understand that these are fairly common problems. and at least there is large amount of is my slide minimized?
Yeah, Dr. Tripathi, may I disturb you? Can you please put it on slideshow?
Yes.
Yeah, thank you.
So whenever we need to understand that sexual problems per se are considered largely couple problems, not a problem of individual, although an individual can come to contact you, but largely it is considered a couple related problem, and in large amount of multinational data shows that at least 50% of couple experience a diagnosable sexual health problem at least some point in their marriage or relationship. And there are some very important basic fact that in females, this prevalence is slightly higher in comparison to male. Age is one of the strongest predictor of sexual health problems. That means as we age, problem of possibility of having sexual problems increases, and quality of life is strongly determined by sexual aspect of an individual. It is not only directly related to sexual functioning in a couple relationship, but sexuality in general also is influenced by large amount of other biological things. That is why this correlation has been established, that sexuality goes quite strongly with overall quality of life of an individual. Before I hope that everybody in this audience at least is aware about sexual response cycle. So I'm not going in much detail, but we must keep in mind the few differences in male and female sexual response cycle. That we know that this desire, excitement, plateau, orgasm, and resolution phase plays quite similar and uniform in large number of male. But in female, there can be more possibility of variations in this sexual response cycle, that some of the females might be having multi-orgasm, some of the females might have sort of lesser frequency of orgasm. Some of females might have lesser amount of pleasure associated with orgasm, but it might continue for some more amount of time. Some females might not experience orgasm at all, but still they may enjoy sexual activities. Some amount of female might not have orgasm and might be distressed due to that fact, and they might come into consultation for seeking help in that regard. But we need to be aware about these wide variety of differences in sexual response cycle of a female once we are assessing the sexual history, and we need to assess that what is normal pattern for this particular individual which is sitting in front of us, rather than thinking there is something normal for population in general. I also want to reflect on somewhat what usually happens in the clinical practice of a psychiatrist, the people who are coming to seek help from us. Because the people who are coming to seek help from urologist may be slightly different. People who are coming to seek help from skin and venereal diseases specialists, dermatologists, in relation to sexual problem may be different, or endocrinologists may be different. But what have been my experience in the last 1.5 decade of my clinical practice in sexual medicine, that I see that a good number of people come with myths, misconceptions, insecurities, inappropriate experimentations, or they have other neurotic illnesses like depressive disorder, anxiety disorder, and adjustment disorder, and they are presenting to us with a sexual health related problem. That syndrome is a fairly common situation, and similarly in quite number of cases organ related anxiety, that their concern related to their penis size, shape of the penis. They have this reporting that they have veins on the penis. So these things are pretty common, as well as the performance anxiety related issues in male who are sexually active, or even in the people who are not sexually active. Then inappropriate attachments in the relationship, issues related to breakup or other sort of relationship difficulties, and then the proper sexual dysfunctions, disorders, and gender dysphoria related things, which we commonly get to read in our textbooks. It is also important to understand that a large number of our clients are quite young. That in my clinical practice over a long period of time, I see that a good number of patients, at least 20% of patients are even less than 20 years old. And up to 50% of clients are less than 35 years old. And in India, it is very common that unmarried, single, and even people who are married, they come without partners. So when we are assessing or planning management of patients, we need to keep in mind of these things, because some of the clinical management protocol written in standard textbooks might not be applicable as such in those kind of clients. So we need to improvise or need to Indianize the treatment module for those kind of clients. Another important concept before we begin assessing any person with sexual problems is that we have very commonly heard about biopsychosocial model in psychiatric disorders, and we all are aware about these things. So these biopsychosocial factors are very relevant in sexual functioning in health and diseases also. But there is another factor here in sexuality, because we have said that sexuality is often a couple related issue. So there are relational aspects which is important and need thorough assessment. Those relational aspects may be interpersonal relationships like sexual intimacy and non-sexual relationship between the couple. Amount of marital discord or couple discord, more better to use in these days. Mutual trust between the partners sexual health or sexual health problem, because in a good number of cases we might see that partner is also having a sexual dysfunction that is either exacerbating the client's problem, help in maintaining the client problem, or client is falsely implicating his sexual health issues as disease, but his partner might be having problem. So, or desire discrepancies. So these are relational aspect in addition to usual biopsychosocial things which we discuss in all other psychiatric disorders. So I'm sure that psychiatry residents are fairly conversant with these concepts. Now, we also understand that when we talk about influence of multiple factors like biological, psychological, social, or relationship factors on sexual problems of an individual, we also need to understand that all these factors do not simultaneously act on the person's problem, because having this longitudinal aspect or concept of management of sexual problem is likely to help you much better in understanding an individual's sexual problem. Some of those factors might be acting as a predisposing factor, like constitutional or developmental factor. That means a person who is very shy or who is very introvert, or the person who is sort of timid in relationship. So these factors might not be immediately relevant in precipitation of sexual health problem, but they may act as a constitutional or developmental factors relevant to sexual history and its management later on. Then there can be some precipitating factor like failure in one sexual act during an relatively anxiety provoking situation, or some medical problem precipitating sexual health problem at one instance. Those sort of things we need to understand. Then after the illness has been precipitated, a whole range of maintaining factors set in, that the performance anxiety which is building up, then the person's inability to find partner or inability to have confidence to go in new relationship, those sort of things might act as a maintaining factor. So we need to understand that even though there can be biological, psychological, social, relationship factor, all these factors might act on different trajectories for development of this particular client. Now, when you are going to assess a client, you also need to understand that in today's world, information is no longer a rare commodity. we are living in an era of over information and misinformation. So when if we talk in terms of history taking 2-3 decades back, so there might be issues that you need to provide information or psychoeducation to the client, but we now know that a lot of people have much more information than they are likely to have, and a lot of this information is misinformation or wrong information. So in our history taking and in our management of treatment planning, this is an important understanding that what kind of information person is having. So assessment of this factors is very relevant. What is the source of information and how much they believe on that information will be very relevant in understanding the psychosexual problem of the person and context in which you have to start planning the management of that individual. So internet is one of the most important source of information as of now. So we know that for everything in the world now, the first reaction is to see the internet. It is not that ask my brother or ask my mother or whatever the simplest or most difficult thing in the today's world. So sexuality is such an issue that almost everyone in today's world is going on the internet, checking on their symptoms on internet and trying to make sense of what they are going through before they are sitting in front of you. So we need to be cognizant of that fact. And there are lots of myths and misconceptions related to sexuality. And those myths and misconceptions do play a significant role in large number of psychiatric disorders. And large number of these myths and misconceptions are prevalent due to amount of misinformation available in our society. Amount of misinformation that is portrayed in media, movies, pornography. So those factors do play a significant role. The way history is, we need to do assessment of the client or plan management. So these issues related to masturbation, organ size, as we have discussed, or desire discrepancy sort of things. So there's large number of myths and misconceptions that must be kept into consideration whenever we are planning assessment of patient presenting with sexual health problem. So you might be wondering that I am not talking in a the textbook manner, the way how to assess history, because I am trying to emphasize the relevant factor which are different in our culture or society in comparison to what is written in textbook. So some of these factors are very much prevalent in our society because of several issues which we might talk later on during discussion. And some of these factors that the very easy availability of false information that is promoted through these advertisement. I am not sought these advertisement from small or some discrete kind of books. These are advertisement taken from the largest daily Hindi newspaper in our region. So we can see that what is amount of misinformation that is prevalent and how openly these misinformations are distributed in our society. So no wonder there is large amount of these issues in almost all people having sexual dysfunction. Now, when we start evaluation of sexual health problem in an individual, the few important things that need to be kept in consideration that physician attitudes is one of the factor, because sexuality is such an issue. We call that sexuality is taboo subject, specifically in our Indian context, that a lot of time even physicians might not be very comfortable in talking about sexuality with their clients. So the physician must practice, learn, read so that they make themselves comfortable in discussing about the sexual health related issues with the client. So when they are comfortable with the sexual knowledge, when they are comfortable with their own sexuality, then only they can make the person sitting in front of them comfortable. So physicians must make all the effort so that they are comfortable in talking about sexual matters. I'm significantly emphasizing because the people who are not trained in sexual medicine, this is one of the, in a large number of survey, has been shown repeatedly that a large number of physicians themselves are not comfortable in talking about sexual related issues with their client. That is one of the biggest hindrance in taking a proper sexual history. Then another important thing is that sexuality is highly moral or ethical laden subject, that my moral values might be very much different. That I strongly believe is that monogamy is the only thing that should be practiced in this world. Nobody should have extramarital affairs. Nobody should have premarital sexual intercourse. But these are my moral values. They can be right in my personal life's context. But whenever we are assessing the client, we should not impose our ethical or moral values on the client. So this is an important thing, that you need to keep your professional and personal life in relation to sexuality separate. And you need to develop an objectivity, and you need to develop a non-judgmental attitude before you start assessing or taking a good sexual history. And do not obviously judge the client based on information provided. That actually when if you will practice the sexual medicine, you will see a large number of clients, a 15-year boy sitting in front of you saying that I have 3 partners. So you might not feel very comfortable listening this information, but still you have to remain objective and do not judge the persons on whatever they are saying, because that is what you have to do as a clinician, to remain objective and non-judgmental. We discussed this thing that talking about sex and sexuality is not very common in health setting. Lot of undergraduate student almost do not get any training or exposure about talking about sexual health matters, and whatever little information they have about sexual health matters is related to assessment of sexual functioning and dysfunction in relation to infections, mostly HIV. So those sort of things are there that we need to be aware about. What are the common barriers that has been reported for assessment and management of sexual functions? That discomfort and embarrassment, lack of time is another thing, because often assessment of sexual issues might take some time. So in private practice, a lot of people might have that kind of time, but in government setup or might be training setups, a lot of people might find that they do not have enough time. That is why they try to skip that kind of information. But in many cases, that might be a very relevant part of history and might improve your attachment, your ability to comprehensively manage the patient. So whenever possible, appropriate amount of time should be devoted to this thing. Then lack of ability, training and skill, obviously. Personal factors like value, ethics, religion related factors, that you might judge somebody on the basis of religion, that how much sexually active or sexually comfortable they might be talking about sexuality related issues. So but these biases may be your own biases, and they do not have anything in real life. So that we need to understand that our personal biases related to religion or age, or if you are assessing a patient of 65 years old, old person, so do not spontaneously presume that this person will be sexually not active. So these kind of thing we need to understand and keep in consideration when we are thinking about assessment of sexual dysfunction. Then whenever there are large differences in age between physician and their client, then they also a lot of physicians do not feel very comfortable that like a 30-year-old person is trying to assess sexual history of a 65-year-old person. So or a male person assessing history of a female client, or a female physician assessing history of male client. So those sort of issues can be sorted out if there is proper amount of training, exposure and practice during assessment of sexual history, and that can take away these kind of discomforts. and lack of awareness about where to refer if the problems could not be handled by myself. So what are the general instructions when you start assessing the history that put the patient at ease? What does this mean, that putting the person at ease? That you say that something that normalizes sexual dysfunctions or concerns related to sexuality. So what you might say, that something like, as we know, sexuality is very important aspect of life. Sometime the problem you are having also might affect sexual related issues. Are you comfortable in talking about that, or are you willing to talk about that sort of issue? This is icebreaker questions. Okay, so that kind of things might be said in start of the interview, that might put the person at ease, and they do not feel offended if the sexual history is started during assessment. Then using appropriate body language is an important thing. Providing assurance of privacy and confidentiality. Although clinicians assume that this conversation is confidential and patient know this, but whenever you are talking about certain uh, issues related to sexuality or some other aspect in psychiatric history, like extramarital affairs or substance use or these sort of things, you must uh, affirm that this information is kept confidential, it is private, and would not be shared with anybody without your prior information and approval. So saying this will give the confidence and will improve the possibility of getting right history. Then as assessment for any clinical condition, we say that start with open-ended questions. So do not start with, do you have erectile dysfunction or do you have premature ejaculation? Always start with open-ended question. There's a suggestion of one such question here, that suppose you are trying to assess a person who is having diabetes, and you are saying that as sexual health is strongly related to diabetes, do you have any concern to share about your sexual health? In place of diabetes, you can put any of our psychiatric disorders, schizophrenia, depression, anxiety disorder, somatoform disorder, or something like that. Then move to close-ended questions once patient become more comfortable in sexual matters. There is another important suggestion here, that quest for details must be adjusted to the patient's level of comfort and sensitivity of the information. What does this actually mean? That you must see that if you are asking question, how it is not only what response is coming, how the person is responding. If they are comfortable in talking, they seem eager and at ease when discussing the issue, or the person has suddenly become much reserved, not making eye contact, or feeling that they are not comfortable. If you are seeing those sort of things, you must recognize the discomfort, and you must say that it seems that you are not comfortable in talking about these things. It is okay. It is not mandatory to respond all my questions. If you are comfortable, then only we can proceed with this part of assessment. Otherwise, we might leave it for another day or whenever you wishes to talk about it. So if you will recognize the discomfort or distress of the client and address it, it is quite likely that the person will be more cooperative in the further interview, or at least will say that I will come next time about this issue. So it is their choice now, that whether they will come for this thing or talk about this thing on next assessment or not. But this option should always be given, and this ability to assess the person's level of comfort or discomfort is important in assessment of sexual information. Remaining aware of patient's body language, tone, gestures, sign of distress or unwillingness. So I will again re-emphasize that it is not only the answer that person is giving, you also need to see that what kind of other things are happening with the person. And you can sympathetically encourage, obviously, that it is okay to talk about this thing. We are doctors. We often talk about these issues with other client, and we are able to help if the people are having any difficulty in that area. There can be another context when the person is primarily presented to you with sexual health problem. So many of these situations might not arise because the person is then might be very forthcoming, very comfortable in talking, and might be very much open about those things. So these many of these contexts might not be present there. But in large number of other situations where you will be talking about sexual matters, some of these information might be relevant. So students will have again a brief quiz to break the monotony before we progress. So there are two brief cases, and this is a quick type round. So read this question: that a couple in their 50s who are happily married for several years, on a routine health checkup, wife reported that they have sexual intercourse once every couple of months. So tell me, what is happening here? I open the chat box. So can anybody tell me that what is happening here quickly?
Residents, you can quickly type in the chat box.
That's very good. The first response I like, because there we cannot say that what is normal, it is normal or not. It can be normal, but it can be sign of some problem. What I'm trying to say, just because a lot of time what happens that merely based on this information, you jump to a conclusion that it is normal or it is some illness. So both these conclusions are not right. This is my point on this slide. Okay. So we need to talk about more about these things, and what more of these things should be assessed, we'll talk about later. Okay. So if you are presented with this information, do not jump on conclusion that this is happening. You need to sort some more amount of information, and what that information is, we'll talk about later. So here is the next question for you. So quickly, can you type what is happening? That a woman is married for 5 years. She is reported to experience orgasm only in less than 10% of the partnered sexual intercourse. She is able to achieve orgasm in most of her solitary masturbations easily. Can you quickly comment that what is happening here? Okay, somebody saying that it is PME in husband. Any other possibility you might think? Okay. So lack of foreplay, somebody is saying. Any other suggestions or ideas, or can we think more in terms of clinical diagnosis or those sort of thing? So because we have limited time, I will not be able to spend too much time here, but keep these two cases in mind when we discuss the further slides. You need to keep in these two cases in mind. Okay. So how to, if you are presented with this kind of information, how you go about an assessment of these cases, and how you will form a comprehensive sort of scenario for this person. That is what important in understanding. So how to diagnose a case of sexual dysfunction? Now you have been presented with some problem, some information has been given to you, and how you go about diagnosing sexual health problem. So what is sexual health problem? Before we should say that what is the scientific definitions of sexual health problem. So sexual health problems are a group of disorders that are typically characterized by clinically significant disturbances in person's ability to respond sexually and to experience sexual pleasure or experiencing pain. Okay. So what is important keywords here? That clinically significant disturbances, ability to respond sexually, sexual pleasure or pain. So these are the key questions here, keywords in this definition. Also, we need to understand that in lot of presentations in sexual OPDs, myths, misconceptions, faulty techniques, inappropriate expectations are surprisingly much more common that we might think. Okay, so we also need to, because in lot of your responses, it was also coming that it might simply be a faulty technique, that the enough enough foreplay is not being done in that case, or some myths or misconceptions related to that kind of thing, that you think that a 50-year-old couple should have sexual intercourse in couple of months. It is not normal. One 50-year-old couple might be having sexual intercourse daily. Other couple might be having sexual intercourse once in a year, but both can be normal. So we need to understand and acknowledge the great variety of individual differences that might happen in individuals before saying that whether it is normal, whether it is abnormal, whether it is diagnosable condition, whether it is in need of any treatment or not. And that is how we need to discriminate between sexual. See, these differences, that sexual concern, difficulties, problem, dysfunctions, these are not very watertight compartment or clear-cut things. As a clinician, but we need to understand that whether it is sexual concern, that means not a diagnosable health problem, but they are having some distress due to that, and that is why they are talking it with you. Or they are experiencing some difficulties only, they are experiencing some transient sexual problems versus a clinically diagnosable sexual dysfunction. So if we are able to differentiate those sort of things, it will be better. So just quickly going through that, in the current context, what are the sexual dysfunctions that are diagnosable through our diagnostic criteria? The DSM-5 says that there are 3 important sexual dysfunctions in female sexual interest and arousal disorder. These are clubbed nowadays. There are no separate interest on arousal disorders now. These 2 has been clubbed. Then female orgasmic disorder and genitopelvic pain and penetration disorder. It includes both vaginismus and dyspareunia, as were separate in previous classifications. So in female, as per DSM-5, these are the 3 sexual dysfunctions. In men, there are 4 sexual dysfunctions in this classificatory system: male hypoactive sexual desire disorder, erectile disorder, premature ejaculation, and delayed ejaculation. And all these can be substance or medication related. So there are certain common criteria for all these disorders, that these problems should occur in all or almost all occasions. That is an important consideration whenever you are thinking about making a clinical diagnosis. That dysfunction, that premature ejaculation should not have happened only once in last 6 intercourse. It must be a predominant feature before making a clinical diagnosis. It should persist for the reasonable period of time, several months. For that, this case, at least 6 months before we say that this can be a clinically diagnosable condition. And obviously, it is not better explained by any non-sexual mental disorder. That is, it is not happening due to depression or anxiety disorder, or severe relationship distress, or substance medication, or any another medical condition before saying that this is a primary sexual dysfunction. Once we are making a diagnosis of sexual dysfunction, then we also try to categorize into following subdivisions for better characterization of problem and proper management plan, that whether the problem is lifelong or acquired, because it has a lot of bearing on management plan. Whether the problem is generalized or situational, because it can give you several important clues about etiology of the condition. Problem is generalized or situational. Then the severity of problem, as we say about severity of any other problem, whether the problem is mild, moderate, or severe, depending upon the distress or amount of instances when they are having problems. We talked about what are the problems or what are the dysfunctions. Then we talked about what are the common criteria. Then we talked about what are the sub criteria. Then is another important concept in this diagnostic scheme, that what are the important or possibly relevant source of sexual problems in those scenario. That what are the partner factors that may be relevant and important? What are the relationship factors that are important? What are the individual variability related factors? What are the cultural and religious factors and medical factors? So these things need to be separately assessed because they are very important component of management plan. So again, a quiz. So who will tell me what is happening and how can we categorize these things? 5 seconds. So what is happening, guys? Can anybody type what is the diagnosis here? It is obviously written on the screen itself. So we can see that yes, lifelong generalized female orgasmic disorder. Okay. So what I'm trying to say is that if we are doing this side of categorization, we can also think in terms of what can be the most possible etiopathological factor that may be relevant here. Being lifelong, being generalized problem, it is quite possibly that there may be some organic factor involved, some hormonal issues may be involved, or important psychological issues like from past sexual abuses. So your just diagnosis also help in understanding that what can be the possible etiopathological factors in that kind of context. Once more, we'll do this. Actually, these questions used to come on the second, but somehow the slide is showing directly. It is okay. So you can see that what is there, that this 25-year-old male is experiencing early ejaculation and poor sexual satisfaction with his spouse. No issue with other partners and previous relationship. So we can understand that in this context, the problem is not lifelong. It is acquired. Okay. And it is also not generalized. It is a situational problem. The person is having premature ejaculation. So it is much more likely that the person is experiencing this premature ejaculation due to some relationship problems, some guilt issues, some performance anxiety related to fear of pregnancy, STD, or some substances, or these kind of thing. Once you get to know the problems the person is experiencing, you can start planning about what can be the possibility of pathological factors, and that will be helpful in management of the case. Okay. So thank you very much. That is all with the slides. I hope that we will be having a lot of questions, and I understand that there is a lot of other concepts related to this thing, but we'll try to answer in the question answer session. Thank you very much.
Thank you, sir. So people, if you have questions, we are waiting for them in the chat box. Maybe you can unmute yourself and ask also if okay with that.
Hello.
Yes, please go ahead.
Uh, Ma'am, I have a question.
Yes, please go ahead.
Sir, I saw a patient, a 32-year-old male. He claimed that he is homosexual and he's married since last 2 years. And in his last 2 years, he has hardly 2 to 3 times sexual intercourse. There's a lot of marital discord between two because of this issue. That person came to me and says, "Sir, please prescribe some medication so that I'm able to perform sexual intercourse." Uh, so that my wife is satisfied, because I feel guilty of not being able to perform my job, my duty as a husband. So he want some medication कि anyhow please provide some medication ताकि मैं सेक्सुअली सेटिस्फाई कर पाऊँ उससे. बाकी इमोशनली मैं उतना कनेक्टेड नहीं हूँ. मैं किसी भी तरीके से मुझे शादी कंटिन्यू करना है, मैं बच्चे प्लान करना चाहता हूँ. सो तो ऐसी कंडीशन में क्या करना चाहिए सर?
Sir, you're on mute. Sir, आप mute पे.
Thank you. Sorry. Thank you for letting me know. So thank you very much for your question. And I am saying that this is not an uncommon situation which you have encountered. Anybody who is practicing sexual medicine for some time will see several such cases coming to us. So what do you think that this is why this situation is arising? Because we know that in sexual context, it is not only clinical factors that are relevant. There are a lot of social, cultural factors that plays an important role. Homosexuality is such an issue that people in our culture are not very comfortable in talking about those things. They are unable to disclose this information to their family members. They are unable to confront this information even to themselves, that they feel that somehow they should be able to fit in the world and they should be able to do their duties as prescribed by society as a husband or a son or whatever in this context. So first, because we know that if a person is truly homosexual, it is very difficult to have arousing feeling towards opposite partner. But we also have seen that you need to understand that this orientation is not a black and white phenomena. The orientation also lies on a sort of a spectrum, that you might have heard that a lot of people are bisexual, that they might be equally interested in males and females. Some people are more interested in males, but they can also take interest and perform with females. Some people are not at all interested in opposite partner, and they are preferably or exclusively homosexual. So depending upon these concerns, we need to give advice that what is happening with you is not something you are not, there is no medical abnormality involved here. You are not you are not personally wrong, or you are not, this is not your mistake that you are not able to have sexually arousing feeling towards your partner. But still the person might plead that to fulfill my responsibility as a son, as a husband, as a good citizen, I need to do something in that kind of situation. So see, we all have attempted those kind of things, that we tell these kind of client, we counsel कि भाई ये तुम्हारी mistake नहीं है, ये एक natural biological phenomena है. चॉइस नहीं होती किसी की अपने ओरिएंटेशन को चूज करने की. दिस इज अ प्योरली बायोलॉजिकल थिंग. जैसे आप स्किन के कलर को अपने चूज नहीं कर सकते, अपनी हाइट को चूज नहीं कर सकते, अपने हेयर्स के तरीके को नहीं चूज कर सकते, वैसे ही आप अपने ओरिएंटेशन को नहीं चूज कर सकते. ये नेचुरल प्रोसेस से इवॉल्व होता है. अब आप जिस भी सोशियो कल्चरल कंडीशन के हिसाब से इस सिचुएशन में हैं, तो व्हाट मतलब you can sort of say, so if you'll do this sort of counseling, it will reduce at least the guilt and the sort of the situational anxiety that he is experiencing. और इस तरह की सिचुएशन में हम लोग कई बार ट्राई करते हैं कि अगर कुछ नहीं हो सकता तो गिविंग सम लो डोज PD5 inhibitors and giving some low dose medications which in general enhances their ability to perform sexually might be helpful in that kind of clinical situation. But again, it is dependent upon the how strong the person's orientation is playing. If a person is strictly homosexual and he does not have not having feeling at all towards partner, even with imagination during sexual intercourse, is not able to have any amount of excitement, that it might be a very difficult situation. We will not be able to do anything to fulfill the person's demand. I hope that I have been able to tell you some response. And I
Yes.
would also request Suparna ma'am, because she might have handled such situations more commonly. So to tell that what is the what she thinks can be done in this situation.
You are very right. You have to give him something to alleviate his anxiety, a very small dose, as well as, like you mentioned, a tadalafil or sildenafil equivalent something for him to act under a situation. But that cannot go on for lifetime. That's very important. You can't give him a guilt feeling that why did you get married in the first place when you knew you were a homosexual. But in under these conditions, I think you have to be sympathetic and give him something to support him.
Okay. Thank you, ma'am. Thank you, sir.
I think in the chat box, Dr. Utkarsh is asking if you can say something about porn use and ejaculatory failure, common issues in the young couples.
Yes. So this pornography, actually, this pornography per se is a thing that has several angles to it. The pornography per se can be a useful clinical tool in certain context. Pornography can be a very important distractor in a couple relationship where it is creating some sort of problem between couple. Or pornography can be specifically in young and unmarried couple who are engaging in pornography that can be considered somewhat excessive, that they are engaging in pornography that goes on for several hours in a day, and uh, they are consuming significant amount of time and energy for recovering from its effect. See, because biologically or clinically we cannot say that anything in sexuality can be excessive. What we are trying to define excessive in this context is something that is not very fruitful or helpful in the person's life context. Suppose a student, if he is watching pornography 2 hours on an average in a day, and masturbating 2 or 3 times in a day, and his amount of time related to sexual activities or recovering from effect goes on several hours in a day, that in his context may be considered not very productive and excessive, because this is impacting negatively the person's academic profile as well as their ability to achieve what they could have been possibly achieved. It might not have any other sort of problem. But there are concerns or issues has related that some erectile dysfunction or ejaculatory problems might occur with excessive pornography use. There are a lot of theory proposed due to this sort of thing. And the theory says that because pornography is not a normative sexual experience, this is an excessive and exacerbated sexual experience, that you are watching the bodies which are not realistic, you are watching the activities which are not realistic, you are watching the sexual act which are not realistic. So the brain ability to respond to sexual cues in daily life or real life start getting having higher threshold. So when you are in real life sexual scenarios, obviously you are not going to have partner which is depicted in pornographic movies or that kind of stimulation. So people, it has been hypothesized that due to their need for this exacerbated or hyper normal stimulation, a lot of people are not able to feel appropriately sexually stimulated during real life conditions. That is why they might have erectile dysfunction during that situation. There is another thing that people often masturbate during watching pornography. So this wrong masturbatory practices adopted during watching pornography, that due to time constraint or just by habit, they are trying to ejaculate very early, or they are holding their genitals like penis very tight, or those sort of wrong masturbatory practices might have some deviant influence on their normal sexual behavior. That is why they are might not be able to feel satisfactory sexual stimulation during real life sexual encounters, and might experience difficulties during that. So, in short, the effect of pornography on individual need to be seen in individual context. So there is not one line right or wrong thing. We cannot say that pornography is absolutely wrong and no one should watch it. There, because adolescents are going to watch, almost everybody in adolescence is exposed to pornography in some or other form. But if the person is experiencing the problem, as we have discussed earlier, then you need to understand that right amount of sort of reducing the amount of pornography consumption and just staying away from pornography for a decent amount of time should be able to solve a lot of problem which we are discussing in clinical context. If the person has not developed secondary anxiety or lot of poor self-confidence, or having significant comparisons of self performance with the what he is watching in pornography, those sort of things are also very common, and that need to be handled as per the clinical uh, context of what the person is, what kind of myth or misconception that particular person is having.
Any more questions? You can have it in the chat box.
Dr. Suparna ma'am, if you also wanted to respond to that, your views on this.
Well, I think it was a wonderfully presented topic. Most important, it wasn't what you asked question by question like an structured interview, but it was a very sympathetic, empathetic, and though non-structured way, yet it had a structure to itself. And that was very good thing that I observed in what he talked about just now. So Adarsh, you were very good.
Thank you, ma'am.
Ma'am, if you would like to say something. Okay, there's one more question, if we can take that, sir. Someone's written in the chat box how to counsel regarding the guilt that masturbatory practice leads to sexual dysfunction.
I think I responded to a lot of things in response to earlier question also, but to specifically handle the guilt that masturbation led to sexual dysfunction, this myth and misconception is actually very common. That a lot of people who present to us having erectile dysfunction or premature ejaculation, they report that because they had did masturbation in their previous life or early developmental period, that is the reason for their sexual dysfunction. So to handle this guilt, it has to be told to these individuals that masturbation is not something that can lead to sexual dysfunction. Masturbation is a normal developmental process that almost every individual in their lifetime is likely to experience. You can throw some statistics that large number of statistics says that up to 90% of the male or up to 70% of the female in their middle males have masturbation, had experience of masturbation. And actually, people say that these statistics, on lighter mode, that somebody said did this survey, and they found the result that 90% of the male and 70% of the female do masturbate. And what about the rest? So obviously, they are lying. So, so we can say that almost most of the people do have some experience of masturbation. Masturbation per se is not likely to cause any sexual dysfunction. The amount of semen that individual has is not a finite amount. If you'll keep on producing it, if you'll keep on raising, the body will produce more semen. It is not like that you have got one bottle of quota of semen. If you'll exhaust that bottle of quota of semen, that you are gone for life. Those sort of thing we need to use the common language में उस बात को explain करना है individual को. Then saying that the problem which you are presenting is likely to have several other reasons. Then you need to find out that what can be the most possible etiological factor for that particular kind of individual. So explaining that those additional factors are responsible for the kind of problem you are experiencing is likely to help with the guilt that person is experiencing in this scenario.
And there are 2-3 more questions, but maybe one more question if we can take. The last one, how do we deal with couples where sexual drive is not equal among partners? Sometimes clinically, we encounter couple where women experience marital rape, where the husband's drive is excessive for the wife. How to navigate this situation?
Okay. So desire discrepancies are very common. See, desire discrepancies are not uncommon. But saying that marital rape is happening due to desire discrepancy, there are a lot of more information that one must understand. First thing that it is more of couples harmony and couples cohesiveness among each other. And a lot of non-sexual factors also play a very important role in sexuality of a couple. So it is not only desire of a person that how things are playing between the couple. The desire has also been described to two subtypes. One is spontaneous sexual desire, another is responsive sexual desire. And large number of differences has been noted between men and women. That it is said that in largely men are likely to have more spontaneous desire, and females are likely to have more responsive desire. So these are not things written in stone, but these are things that are more likely. So what is, I hope that you can understand what is spontaneous desire and responsive desire. That desire kindles in response to sexual stimulation, that a partner goes near the other person, he says pleasing things, touches her, and sort of initiate the sexual encounter. Then in response to that, the person start having sexual desire. This is much more common scenario with the females. And if there is good amount of intimacy, bonding, and some amount of passion in relationship, even if the other partner is not experiencing desire, they might contribute to the sexual act or sexual satisfaction of each other, even when not experiencing enough sexual desire. So it is in this context, what you have written, it seems that the other aspect of relationship, what we call that in a healthy relationship, there should be enough amount of intimacy, enough amount of commitment, enough amount of passion, these three factors. So there is some sort of problems in those areas also. In it, only desire discrepancy is not likely to contribute to this kind of situation where we are forced to say that female is getting maritally, there are instances of marital rape in that kind of situation. So it need to be seen in a larger context rather than seen from the angle of only desire discrepancy.
Thank you, sir. There are a few more questions, but I think we are running out of time. And any last comments, Suparna ma'am, Shilpa ma'am, before we move into the quiz?
Well, I congratulate Adarsh for giving a very good talk. I don't think he has missed out much. And it was non-structured, and yet it was structured interview way. And I think he has done a very good job. Whatever Shilpa wants to say.
Thank you, ma'am. Firstly, I thank Dr. Tripathi. I think you made it very clear about even the residents, especially residents, because this was meant for the PG students, that their own misconception, their own attitude towards this history taking, and then what to include, how to look at it in a larger perspective, how not to have their own ethical or moral beliefs coming into taking this history. So I think that was very important. And then you enumerated the dysfunctions and gave examples to figure out how we can differentiate between lifelong versus situational, or what could be the reason, whether it is acquired or it is whether it's related to any organic condition. So I think it was very helpful for the PG students. I presume that it was a very, and given the questions that are coming up, though they came up a little late, but I think they will be able to take psychosexual histories better, whether it's in another context or if a person presents with a sexual dysfunction. So thank you very much, Dr. Tripathi. And I thank Dr. Suparna ma'am for being a wonderful chairperson and giving her inputs as well in this. So it was a double whammy for us. Thank you.
Thank you, Shilpa. Thank you.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am. So I think that gets us to the quiz, which is the last bit, and I hand over to Mansi Jain for that.
Thank you, Prajakta. Thank you, sir, Tripathi sir, for this wonderful talk, and thank you, Shilpa ma'am and Suparna ma'am. So we have a case vignette. So depending upon whatever sir has taught today, there's a small case vignette, following which there'll be 5 questions which are related to the case vignette. They're quite simple. I'll be sharing the slide for the case vignette. You can screenshot it if you want, because after that the questions will be in Zoom poll. It's a multiple choice question. Each question will be displayed. You have to just click the right answer and at the end submit the quiz. Don't submit each question individually. All right. So here's the case vignette for us. So we have a 27-year-old male and a 25-year-old female who've been married since the past 6 months and have presented to the OPD with complaints of having unsatisfactory sexual intercourse since marriage. This is their first sexual encounter with each other, which was on their honeymoon. And upon inquiry, the male partner is saying that the first time they tried to have intercourse, the wife experienced intense pain and pushed him away as a reflex, because of which he lost his erection. And since then, he is very afraid every time he thinks of sex because he thinks he might hurt his partner. And with that anxiety and fear, he is not achieving an erection. Similarly, the wife reports that she also understands that it was a knee-jerk reaction that she had at that time, but she's tried to approach him. But every time she thinks of penetrative sex or any form of sexual intercourse, she becomes very tense, and even the thought is very uncomfortable for her. The couple has tried to have intercourse despite these problems, but are still unable to enjoy it or and have reached out for help for the same. The male partner reports that he is able to masturbate and achieves orgasm when he does that. The female partner reports that she has never masturbated and thinks that it's a dirty habit. So this is the case vignette, and now we will go to the questions, which is in the form of a Zoom poll. So Mr. Yogendra will put up the questions. So
Can you
this
see
is the, sorry?
Can you see the question?
I can see. Are the participants able to see? Prajakta, can you let us know?
Yes, we can see.
Just scroll down.
Yes, we can scroll down, but how do
Yeah.
you answer?
No, madam, co-host cannot answer.
So you and I will not be able to answer, Prajakta. The
Okay.
participants will see them in a multiple choice format. So the first question is, what best defines the difficulty experienced by the female partner? So if you remember, she had intense pain when penetrative sex was tried for the first time. And ever since that, she's been having difficulty even thinking about sex. She becomes tense because of the first experience. Going to the next question. The second question is, what would be your approach towards the male partner's problem? So, should we kind of prescribe, that's sildenafil, the first option. We advise him to stop masturbation, refer to urology for penile Doppler, or explain the effect of performance anxiety to him. The third question is, which of these would you want to inquire about in detail with the female partner? So if there were two things that were mentioned, that she's never masturbated and she thinks that it's a dirty habit. The options are history of abuse, her views about sex and sexuality while growing up, prior sexual encounters, or all of the above. Fourth question is involuntary contraction of perineal muscles surrounding the lower one-third of vagina during penetration is known as female climatic disorder, vaginismus, dyskinesia, or vulvodynia. And the last question is, which of the following points towards organic cause of an erectile dysfunction in males? So not psychological and organic cause. So inability to achieve erection with a partner, absence of morning tumescence, presence of semen in urine, and presence of paraphilias. Twenty seconds more and then we will end the poll. I hope everyone is answering. So we'll end the poll now. So the results are, so the first question that we'd answered, the answer is dyspareunia. So dyspareunia is basically painful experience during penetrative sex. The answer to the second question is explain the effect of performance anxiety. Sildenafil will not help completely. We will have to explain that this is because of anxiety that he is experiencing. Uh, which of the following you would want to inquire in detail with the partner? The answer is all of the above. So what she experienced, the vaginismus during penetrative sex and all of the other things that were mentioned, that, she's never masturbated, thinks it's a dirty habit, which tells us that her ideas about sex and sexuality might be different. Also, vaginismus is very common in people who have experienced abusive sexual experiences or sexual abuse. Involuntary contraction of the lower one-third of vaginal muscles is known as vaginismus. Vulvodynia is pain in the entire vulval region. And the last answer is organic cause of erectile dysfunction is absence of morning tumescence. Presence of paraphilias does not tell us anything about the erectile dysfunction. So this is the end of the quiz. We will tabulate the results and probably in the next Tenacious Tuesday meeting, we will share it with everybody, whoever's answered the most correct answers.
Thank
All
you,
right, we can
Mansi,
end.
ma'am.
Thank you.
All right. We hope that this was a really interactive and different session for all the PG students who find this topic very difficult to discuss, maybe with their faculty members or with their seniors. Having said that, we also have an announcement that on the 20th, we have another mid-month session for part 2 of MSc, which we are conducting on popular demand. So please join in for that. We will send you the details on the group, and do fill up the feedback through the link that we have shared on chat. Shilpa ma'am, if you want to say some last words, or we can end.
No, no last words. Thank you, Prajakta, for conducting it so well. And thank you, Mansi, for that quiz. It was really well thought of and very relevant case vignette and the questions.
Thank
So
you, ma'am.
thank you, both of you. I again thank, I don't know if they've left, but I again thank Dr. Tripathi and Dr. Suparna Telang and all those who attended this session, all the residents. I hope it helped you and it will help you later in your psychosocial history taking. So thank you. Please join us again next Tuesday for the MSc Part 2. It's on popular demand. So it is for you that we have kept the second session by Dr. Sushil Gawande. And also please give your feedback. Thank you. Thank you so much.
Thank you.